Thank you, Dr. Frank, for joining us on this episode of the Cancer Project podcast. We really appreciate the opportunity to talk to you.
Great to be here, David. Thanks so much for having me.
Before we came on, I had asked you, of course, we're here at Astro right now, and there's been different papers released, and there's lots of things going on in the industry. And one of the hot topics has been this paper, or I guess it's called the TORPEDO study or trial that came out of the UK recently. And I was just curious your thoughts on that paper and the data that got released.
Well, thank you, David. And I was thinking that, the TORPEDO trial, I'm actually an advisor on that study. They asked me to be one after they had developed the trial, and they asked me to come on and just give them some insights. So the TORPEDO trial is near and dear to my heart because I'm a former submariner. And so having the name Torpedo really was, I thought, pretty insightful and fun to hear. I think there's a couple of things when we look at the data around proton therapy, and also the paper that's coming out in Lancet shortly, which is extremely exciting from our data in our phase 3 trial. I think the one thing that I initially took home from this is that for the first time, we've got confirmatory evidence that IMPT is comparable and it's no longer investigational or experimental.
Okay.
And for patients with oropharynx cancer. And what I mean by that is in the phase 3 trial that we completed, which is a 440 patient trial, multi-institution, 17 proton centers, 21 institutions, we were able to demonstrate comparable outcomes. And that was important to demonstrate because when proton therapy with IMPT first was developed, and that was really in 2010, 2011, when we first started treating our first patients with IMPT, there were a lot of concerns amongst all of the industry that precision could also be a detriment.
Okay.
And especially in head and neck patients, when patients are losing weight and the tumors are shrinking during the course of the treatment, that precision could make inaccuracies in terms of where the protons go could cause patients to recur or could cause more toxicities. Yeah. And so we needed to be able to prove, first of all, that we could achieve at least comparable outcomes with the standard of care, which is IMRT.
Okay.
And so our trial was the first confirmatory trial. It was a non-inferiority trial design. And we were able to confirm with progression-free survival that IMPT, it was a positive trial. IMPT is non-inferior to IMRT.
Okay.
So that was a big point. Now, what the trial also showed, which were two exciting things from a de-intensification, because these patients are suffering through their treatment.
Right.
They're having significant amounts of mucositis. They're having loss of taste. They're having difficulty swallowing. They're needing feeding tubes. And what the historic data had been shown is that 60% of patients are feeding tube dependent at the end of their treatment.
Okay, wow.
So this was an important de-intensification, and many de-intensification efforts have been ongoing to try to reduce the toxicity of treatment. One de-intensification approach has been surgery, where we use TORs, but those trials were shut down because there were patients that had too many fatalities with the surgery. Other attempts was with systemic therapy, where cetuximab was attempted to be used as a means of removing cisplatin.
Okay.
And that trial did not actually showed it was more toxic for patients. And so that didn't work.
Yeah.
But proton therapy in our trial really demonstrated significant reduction of gastrostomy tube and feeding tube dependence. It showed and that was an absolute difference of 13% from 40 down to 27, which was significant.
Okay.
It showed a significant reduction of dysphagia or difficulty swallowing.
Okay.
Significant reduction of xerostomia or saliva, maintenance of saliva, which is very important to patients.
Okay.
And also a significant reduction of lymphopenia, which affects the immune system. And we'll talk a little bit about how that imparts. And that's a very important one because over a course of 5 years, what we are starting to see is a 10% absolute benefit in survival.
Okay, wow.
By patients that have proton therapy over IMRT.
Okay.
And we are seeing for the first time at 5 years that 90% of patients, 91% of patients are alive, whereas in the IMRT arm, it's about 81% of patients. So that absolute benefit of 10% is statistically significant and an unexpected finding, quite frankly, in our trial. So this is an excitement that will be shared when the Lancet, with the Lancet paper that's soon to be published.
What do you think are some of the reasons or explanations for the overall survival benefit? I know you talked about side effects. Do you think that played a role then in this survival benefit?
It's possible. So we have looked at the causes of death of each of the patients. We looked at acute causes, and then we looked at chronic causes. Acute causes are those patients that died within 90 days of treatment, and chronic causes are those that are after 90 days. And what we have found, and then we separated the patients into those that have died with head and neck cancer versus those that died without having recurred or with head and neck cancer. And what we found was about half of patients, or about 5 patients that died with head and neck cancer acutely, meaning within the first 90 days of treatment. It could have been from various reasons. Maybe they had a heart attack, maybe one patient had committed suicide, and that was in the IMRT arm, or patients died during induction in chemotherapy, where they just didn't tolerate the treatment well and passed away. So we saw that. We saw about 3 patients that passed away, or 2 patients that had disease that passed away during the acute phase in the IMPT arm. Interestingly, in the chronic arm, is where it gets interesting because the curves did not separate in terms of survival until about 3 years. And at 3 years, then those curves started survival. So we really are looking at that chronic phase. And what we see is about 18 patients in the IMRT arm died following progression of their disease. And that's important to note because there wasn't a difference in local, regional, or distant control. In both arms, they were roughly equivalent. It was about 97% local control, 96% regional control, and 91% distant control in both arms. But what happened after that is really what's the fascinating piece that we're trying to tease and understand a little bit more. And what we see is the patients with IMRT are dying faster following progression, and there's more patients with proton therapy who are salvaged after they progress. And so what are the mechanisms that we can justify that that's happening? There's a concept called T-cell exhaustion, and that's an element of the immune system, which is what I was referring to with the lymphopenia. And that immune system, what can happen is due to the chronic inflammation that happens with additional radiation, the IMRT, and the dose path to normal tissues, that over time, with the decrease in the lymphocytes, that when these patients progress, their immune system cannot activate and respond as quickly and as robustly as the IMPT patients. And perhaps that may be a reason that we're seeing that those IMRT patients are dying faster and not able to recover with salvage in the same manner that the IMPT patients. Again, this is a hypothesis that we're going to be looking at, and now we're in the next phase. We're getting grants to draw blood with the patients in their 3 to 5 to 10 year phase, and we've extended the trial evaluation out to a total of 10 years. We have initial grant with the PO1 that's also looking at chronic toxicities that are not associated with recurrences, like dysphagia, and to see if the swallowing function in patients may result in more pneumonias that then result in deaths. And then the third thing that we're looking at is, with all of the changes that happen with IMRT in the anterior cavity, that can change the microbiome. And that microbiome can have impact on how patients eat and what happens in the GI tract. And it could happen, what can happen with patients with respect to diabetes or cardiovascular disease, that may affect the entire, biome itself of the body. So these are some things that we're looking at to try to better understand what is generating this 10% benefit in overall survival. So let's go back to the TORPEDO study for a moment and say, what did the TORPEDO study, what was its endpoint? What has it shown? What were the conclusions? And do we agree with those conclusions? So one of the things that we identified in terms of the endpoint was a 12-month endpoint. And that 12-month endpoint was looking at feeding tube dependence and weight loss. And they were also looking at a University of Washington quality of life health assessment. So it's one point in time.
Right.
And they used data from different trials to come up with the right number of patients to see if they could come up with something that was statistically significant in terms of reduction for IMPT. And what the overall study was, it was a negative study, meaning at 12 months after the treatment, both IMPT and IMRT arm had 1.7% feeding tube rates at 12 months. And the quality of life instrument was not significantly different between the two arms.
Okay.
So that's all the trial showed.
Right. Okay.
It also showed that and this was I was going back to, it showed that the survival and the local regional control was consistent between the two arms. And so this is a confirmatory study that demonstrated that IMPT is comparable to IMRT and can be considered non-investigational.
Okay.
Right. That's an important point.
Yep.
Now, what the study did not go into detail on was how many feeding tubes and what the feeding tube rate were for these patients at the end of their treatment.
Right.
That's an important metric of how patients are suffering during the course of this treatment. And these patients, because nobody wants a feeding tube.
Right, right.
And if you put a feeding tube into somebody, that's because they can't sustain their nutrition and hydration on their own.
Right.
And that is truly a toxic, total toxicity burden endpoint that I think cannot be overlooked in this trial. And what I saw on the presentation yesterday was that from a quality of life, the quality of life was significantly worse for patients with IMRT at the end of treatment.
Okay.
And 6 weeks after. There was a significantly different amount of suffering that the patients were undergoing that was more consistent with IMRT than IMPT.
Okay.
Now, they didn't show statistics on that yet. What they did show was a bar graph, and they showed significance in bar graph in terms of patients being able to swallow and sustain themselves. What was also, talking to the principal investigator, David Thompson, after the study, he also commented to me that over 50% of patients in IMRT were, at the end of treatment, were feeding tube dependent.
Oh, okay.
Now, you had only 53 patients were in the IMRT arm.
Right.
It was a 2-to-1 randomization.
Yep.
So half of those patients were gastrostomy tube dependent, which implies to me that is considerable amount of toxicity that these patients are undergoing. And you have to remember, in our trial, we had 40% that were in the treatment. And also in our trial, we had 27% that from the IMPT. So it's almost cutting by almost half of the patients that can't sustain their nutrition and their weight during the course of treatment. So I think, those are the elements that we have to tease out a little bit more. They only had a median follow-up of 24 months. So, we didn't see the curve separating in terms of survival until after 3 years.
Okay.
So we don't have that information from this study. What we are planning on doing, which I think is exciting, is we're going to do a meta-analysis with this data, our data. And also there's 2 other randomized trials that are taking place in Europe in oropharynx that are looking at this as well. There's one Danish study called the DAHANKA that's also accruing. And there's another study from the Swedish study, which is also accruing as a phase 2 study. The other ones are phase 3 studies. So we'll have a lot of interesting data to help us understand not only the survival, but the outcomes. And the one data that I didn't present, but we are publishing soon, we're submitting for publication, is that the cost effectiveness.
Right.
And that's going to be very important from a health economic standpoint to help not only our country, but other countries look and understand that even though proton therapy is more expensive, it is cost effective by reducing the toxicities and improving the survival and getting patients back to work.
So it sounds like with the TORPEDO study, what ended up happening is the feeding tube dependence resolved over that 12 months post-treatment. And that's how you go from the half of the patients had feeding tubes down to the 1.7%?
Yeah. Right. Yeah.
Is that pretty typical? I mean, do you see that, I guess, even with the Proton patients, the 27% that needed feeding tubes in your study, would there have been resolving of that issue, I guess, over 12 or 18 or 24 months.
Right. And then so we see, I think, like 2.8% of patients having feeding tubes for IMRT and 0% at a year.
Okay.
And so that's why, as an endpoint, they created something that was, I don't know if one can say that might be what the healthcare system in the UK is looking at.
Yeah.
Right? They're like, well, we just want to see what the 1-year endpoint is. Yeah. But that doesn't tell the story of what the patient is going through over the trajectory of their treatment and their follow-up.
Okay.
And I think our trial has done that. You know, we didn't push one primary toxicity, because the problem with having a specific endpoint like a toxicity like that is that then everybody looks at that and tries to prevent those endpoints from happening.
Right.
And specifically, the nice thing about having a survival endpoint is that you can just take care of your patient. You don't have to worry about a toxicity endpoint one way or another, because it's not the primary endpoint. And you get a less biased assessment of how patients do on the continuity of their care throughout their journey through treatment.
Yeah. So talk a little bit about, you mentioned the cost burden of caring for patients and dealing with these side effects, the cost to an employer, the cost to the family, the cost to a health system. I think you're involved in some research right now looking at that and trying to measure what that cost difference might be. And you've also done some research with the University of Texas as well, and their employee-funded health plan. I think I described that accurately. So talk just a little bit about what you've seen historically and this data that you're working on right now.
Yeah, so I think cost effectiveness is a critical element, especially when you have a more costly treatment that you're trying to bring to the patients. We have to be able to determine, not only that we're going to improve their outcomes, but that it's cost effective, especially for proton therapy, that, building these systems is extremely expensive, and we need to make sure that we can justify that expense. So there are different elements that patients go through in their journey of treatment. There's the initial reaction, of course, but once you start that treatment, patients are typically around the average age of our patients was under 65. So the majority of patients were under 65. The median age was about 61. So these are patients that are not retired and are at the peak of their projected outcome in terms of productivity in their life, right? This is phases of importance. So they want to continue to work. They're not looking to take time off per se. And this is a major disruption in their lives, and also the family's lives. Usually if they have families, their kids are moving into high school and moving into college age. And some are less than that. They're, in elementary. So these are families that are, looking to continue to maintain that sustenance and continue to grow.
Right.
And so when patients have to have feeding tubes, as I mentioned before, that's an assessment of total toxicity burden.
Okay.
That means that they simply cannot eat enough food, drink enough water, control their pain to be able to sustain them. And clearly they're not going to work when they're having a feeding tube.
Right.
And so that all of a sudden, from an employer standpoint, that has cost implications, because now you've taken a productive employee and pulled them out of the company, so to speak. And sometimes, these people might be running their own companies. That has impact. For families, the spouse or the significant other is now trying to become the caretaker for these individuals. And so many of these are double income families. And so now you're compromising some of the care, and some of these patients have to take, some of these caretakers have to take FMLA.
Yep.
So that also impacts employers, even though they're not the patient.
Right.
So because they got to take care of the patient. So I think those are two elements of economics that we're trying to model and better understand.
And those are costs that don't show up in the direct cost of care.
That's correct. They do not show up in the direct cost of care. But
it's still a measurable cost to society.
It's a measurable cost to society, and it has financial toxicity to the patients.
Right.
And then you've got the cost of coming to proton centers, where they have to, come out And that's true. At least at our institution, many people come far and wide, both nationally and internationally. So there's a cost to that as well. Getting an apartment, buying different types of foods, and things to that degree. Then after treatment, patients want to get back to work quickly.
Right.
And what we've been able to demonstrate in we collected 6 different patient-reported outcome metrics. One is a work productivity index. And so we're able to monitor how patients return to work or do not return to work and are unemployed. And what we've seen is a significant difference in the amount of patients from the beginning of treatment to the end of treatment returning to work in the IMPT arm versus the IMRT arm.
Okay.
And more patients that were unemployed in IMRT even out to 3 years.
Oh, wow.
Following treatment. So recovering following the treatment is also, immeasurably has to be measured as well.
Right.
And then what we try to do and model in our cost effectiveness analysis was we looked at the taxes that people would pay if they're working.
Okay.
We also looked at what would Medicare have to pay patients who are unemployed.
Right.
If they're not able to get back to work.
Right.
So those elements also fit into a model that help us better understand cost to society in terms of the overall treatment.
Right.
In the University of Texas system, as you mentioned, we did a particular study looking at how can we get Blue Cross and Blue Shield to pay for the treatment, and then we would come back to UT system, University of Texas system, which pays for all of the care, and it's a self-funded system for the patients as well as their family members.
Okay.
But primarily the patients in this particular study, and looking at what that would mean to the premiums. And what we found between IMRT and IMPT is that the patients had less hospitalizations, less emergency room visits, so there were less cost. We anticipated more cost because of the expense of the treatment, but actually we saw a negative difference in what they would do to those premiums. And so what the UT system did based on that study was they said that these particular indications we were going to approve.
So this was across multiple disease sites?
On multiple disease sites. And there was a generalized approval of proton therapy for those diagnoses for all patients who were employees and their family members.
Okay.
And so that was published. That was a very exciting demonstration of collaboration between MD Anderson and the University of Texas system. We're one of 14 institutions within the University of Texas. Okay. And so that was is an exciting collaboration to demonstrate improvement of care and also helping the UT system reduce the cost of healthcare. Yeah.
Okay. That's amazing. Well, it'll be really exciting to see more of that data get published as well. And it's important. These are big capital investments that we make at MD Anderson, at our center, at the Oklahoma Proton Center. And so it is important to justify the cost that's being committed to these projects. And I think one of the ways to do that is to show that ultimately the cost to society, the cost to payers, the cost to employers can be reduced by treating patients with protons versus treating them with even state-of-the-art photon treatment like IMRT. So we've talked a lot of science and a lot of medicine, and obviously you're doing some amazing things from that standpoint. But I also think that you have a really fascinating background and story. So in the few minutes that we have remaining, I do want to talk a little bit just about how you ended up in medicine, how you ended up as a radiation oncologist. And so tell us just a little bit about Stephen Frank and how you ended up where you are today. And you have to make sure that you talk about playing baseball too. So since that's near and dear to my heart, don't leave that out.
I was very fortunate to have been brought up in an environment of medical care. Yeah. My father, who is my hero, he just recently passed away this year, but he was an internist and cardiologist. He grew up in the town of Huntsville, Alabama. His father was a football coach, and my father ended up playing football at Alabama, where he was Bear Bryant's first fullback at Alabama in 1958. Yes. And he was a Phi Beta Kappa at the University of Alabama, and which there's not many football players that are Phi Beta Kappas. And if you go into the program, there's listed 10 of them, my dad's name, so it's really, but he just decided to go to medical school, forego his senior year. He then became a cardiologist and moved to Atlanta with my mother, and they met at the University of Alabama. And he developed the largest internal medicine group, which was called the Laureate Medical Group over time. And I had a chance to watch him and his love of taking care of patients.
Right.
And so that sort of imprinted upon me where, of what it meant for someone to really love what they were doing.
Right.
And love the ability to touch patients, take care of them, and have that relationship with patients. And so I think I knew early on that medicine was something that I had wanted to consider and wanted to do in my life. And I ended up going to school at the University of Pennsylvania.
Okay.
I ended up going on a Navy ROTC scholarship.
Okay.
And as you implied, I also played baseball as a catcher for several years.
Why did you join the Navy?
So I joined the Navy because I saw what the expense of colleges were.
Okay.
Well, two things. When you go in high school, they give you these little personality assessments.
Yeah.
Where they and you take this test, and then it tells you what you should consider doing based on that assessment.
Right.
So two things came out of that.
Yeah.
One was military.
Okay.
So military popped up as something that I should consider. And the second was a farmer.
Oh, wow. Okay.
Yeah. So, so I thought that was really, I'm like,
you said, well, I've got to do one or the other.
I got to do one or the other,
Yeah, exactly. Yeah.
And we'll come back to farming in a minute because, that's an interesting one. But so I applied to the Naval Academy, didn't get into the academy, but I did apply also for an ROTC scholarship because I recognized the expense of college at that time. And I felt that there was an opportunity for me and that going to medical school, if I really wanted to still go, then I could have the Navy pay for not only college, but then pay for medical school. Right. And so that would be potentially a good track. So I went into the ROTC, and what I came to appreciate was that I took all the pre-med classes. I was also a history major in college. Yeah. And that the more I talked to physicians who were in the Navy, the more they told me that from the time that the decision of what type of field that you wanted to go into may not be your decision.
Oh, okay.
So, and they might need this type of physician, not that type of physician. Right. So they recommended finish your commitment, and then if you still want to go into medicine, do it at that time.
Okay.
So between the sophomore and junior year of college, you have this period of time where they take you and they give you an opportunity to look at every type of discipline in the Navy, from surface ships to aviation, to the Navy SEALs, to the Marine Corps. And so all these different areas you're exposed to. Okay. And I didn't mention submarines. So that was so those are the areas. Yeah. So when I went out to the West Coast, San Diego, for submarines, for the Navy SEALs, and then went up to Whidbey Island up in Washington State to fly jets, and was down to Camp Pendleton for the Marines. And after that summer, I got off the submarine, and I said, I will never go back on one of those again.
Right. Yeah.
I mean, who in their right mind would actually go on a submarine?
Yeah.
And
paint a picture for people that haven't been on a submarine.
I mean, so submarine, they're about the size of a football field. Okay. But they're filled with so much equipment that two people have to turn side by side to walk down. Oh my gosh. Walk down a passageway. Yes. A hall. We call it a hallway, but in the submarine, it's called a passageway. Yeah. And then when you're actually sleeping, the height of your bunk is about from your elbow to the top of hand, and then the width is about the width here. And so, that's your sleeping quarters.
And what that reminds me of? We're here in San Francisco, and I went out to go visit Alcatraz a couple days ago. I mean, that's the picture that's coming to my mind as these little prison cells almost.
Right. But
but you're volunteering to do this.
That's right.
Yeah.
There was probably more space there.
Yeah, it actually probably was.
We had three officers in one stateroom. So, we're all sleeping around top.
Amazing.
And so I was just like, I'm like, who in the world would actually do this? Yeah. And when at that time I thought, I'd spent some time with those Navy SEALs, and I was like, this is the coolest thing I've ever done. And so for about a year, I trained and worked out and with the Marine group at Penn. And then I took all the exams, passed all the exams, but my eyesight, they came to me and they said, you were disqualified because your eyesight needs to be 20/70 correctable to 20/20. And I had about 2100 at the time.
Oh, no.
And you couldn't do any of the stuff that we do
LASIK
today.
and-
They didn't have any of that stuff. So then they said, what else would you like to consider? And they said, we looked at your grades. Why don't we send you down to Washington, D.C. And see if you go into the submarines program. Because every submariner has to meet with the admiral, the head of the chief of naval operations, and the vice admiral of the Navy. So you have to get approved by that. You have to have an interview. You do several interviews. These are technical interviews. They, whatever classwork you're doing, physics, chemistry, whatever it was, they do interviews and they test you. And then the second day is you meet with the admiral. And then if they accept you, then you sit across from a desk. And I can remember the admiral saying, like, you're a history major. What are you doing here?
Yeah, right.
He goes, we got all these people from Caltech, Illinois, Naval Academy. They're all engineers.
Yeah.
I don't want to send you down there and fail at a nuclear power school.
Right.
So I'm sitting, I'm like the last person, waiting, and there's a desk, an administrator behind the desk, and they finally call my name, and I come and I go up and I sit down, and they're either tell you you've been accepted into the program or you haven't. And I had gone down to, when I thought about considering this, I went down to Kingsland, Georgia, to the USS Pennsylvania with my parents.
Okay.
And I met the captain of the submarine. They rolled it. I mean, really went down, and after spending some time really intellectualizing and thinking, where do I want to spend the next 5 years of my life?
Yes.
What I came to realize is that everybody on that submarine are very well educated. And probably the brightest of all the military are on these submarines. And that really attracted me to be with the highest caliber and quality of what the Navy had to offer in terms of my opportunity to spend that type of with. And so that sort of drew me a little bit. And I thought I would consider it,
Yeah.
So I sat behind the administrator's desk. She said, congratulations, you've been accepted.
Oh my gosh.
She said, go down the hall. You have to pick whether you're going to go surface Navy or subsurface Navy.
Yes.
East Coast or West Coast.
Okay.
So then I ended up picking submarines and going to the East Coast.
Okay. And so at that point, did you know kind of what the next 5 years were going to look like, or?
You sort of do. It's pretty mapped out for you.
They do.
So
Okay.
you have to go to nuclear power school, which is a 6-month school.
Okay.
That was in Orlando. And, that was pretty intense because there were engineering classes that I had never taken before.
Yeah.
And you were working, I was working from 4 a.m. to 10 p.m. Each day. It was quite extensive, and people were failing out, and it was...
well, and you had a history background. You hadn't taken much math classes.
But it was amazing experience. And I met some incredible people.
Yeah.
And then after you pass that, then you go to a nuclear prototype facility where you get hands-on operation of a nuclear reactor.
Okay.
And then you have to pass that. And that's a 6-month program, working shift work, 12 on, 12 off, for 6 months. And then if you pass that, then I went up into, they have a warfare school up in Connecticut where you have 3 months of tactical warfare from a submarine. And then they have one final test.
Okay.
They put you into a submarine escape system.
Okay.
And they flood the system. It's in a pool. They flood it down. You have to wear the device, which is that was created, called Dr. Stanky had this device, and it's like you put it over, like a life preserver.
Yeah.
But the life preserver has a hood.
Okay.
And what it does is if a submarine goes down, they put you in this pod. Then they equalize the pressure. The pressure opens up the hatch, and then you escape to the surface.
Okay.
And you have enough air to allow for you to get up. I think it's like 300 to 500 feet.
Okay.
But you have no thermal protection on your body.
Yeah.
The reason that story is important because the first paper I published was when I was up in Connecticut.
Okay.
And I worked with the Naval Undersea Medical Laboratory. And I looked at the submarine escape system and with the question of, is it a practical system?
Okay.
And I did, because when I got to my submarine, I went to Navy dive school. Every submarine requires 4 Navy divers. So they sent me to the Navy dive school in Panama City,
Okay.
where I got that training. So then you go to your submarine, and you're there on your submarine for about 3.5 years.
Okay.
You're assigned to that submarine. It was a fast attack boat. It was called the USS Batfish. I was in Charleston, South Carolina. And we went on deployments that were 7 months at sea in the Mediterranean.
So when you say 7 months at sea, you're literally on the submarine for 7 months.
Yeah.
Okay. Wow.
So you're about 80% of the time you're underwater, and about 20% of the time you're in port.
Yes.
Getting resupplied, and also it's important for morale, as you can imagine.
Yes. How do you maintain your sanity in a setting like that? What does the day-to-day look like in that setting? So
it's about you work on an 18-hour day.
Okay.
Meaning that you've got 6 hours of shift work on where you're operating. You have they move the officers around. So the officers you supervise the operation of the reactor in the reactor space, in the engineering spaces, or you're up in the control room where you might be in the battle station area, which is the compartment that actually drives as the officer of the deck. So we have 10 officers on the submarine and about 100 enlisted. So there's about 110 people on the entire submarine.
Yes.
Together.
All passing each other, turning sideways to go down the passageway. Right. Yeah.
You become a close talker.
Yeah. Exactly. Right. Yeah.
So you ask, they have a little bit of area where you can work out, a small little area.
Okay.
Not much.
Right.
But enough. And then you have 6 hours of maintenance, and then there's 6 hours of drill time. So really, you've got to find these 4 hours every 18 hours at least to get some sleep.
Oh, okay.
So that's sort of how, and there's 4 different cycles of meals. The food is actually fantastic on the submarine.
Really?
The best chefs in the military are on the submarine.
Okay.
Yeah, so that helps with morale.
Yes.
As you can imagine.
Yeah.
So it's a unique environment.
So that may have looked different than Alcatraz then. The food, it sounds like the food was a little bit better.
The food was a little bit better.
Okay.
So it was a great experience. Yeah. But I think I knew after a couple of years of being on the sub that for a career in the Navy, which there's a career path. And by the way, you have to go back to, after 2 years of being on the sub, which is at that 4-year point, you have to go back to Washington, D.C. to take your nuclear engineer's exam. Okay. And to pass that gives you the equivalent of a master's degree in nuclear engineering.
Oh, wow. Okay.
And so every officer has to go back and do that. If you don't pass, they give you one other opportunity to take it. And if you don't pass, then you have to leave.
Okay.
If you do pass it, then you have the opportunity of staying in, doing a shore tour, and then climbing the ladder to ultimately command your own submarine.
Oh, okay.
Which would be the track for an officer of the boat. So I think at that time, I realized that being away from home for that long and that period of time and that type of life was not exactly, when I thought about considering medicine or that type of lifestyle, I felt that medicine was probably the better pathway for me.
Right.
So I took the MCATs while I was on a submarine at sea.
Oh, did you really?
I did.
Oh, wow.
And then I applied, and then I decided to finish my service and not stay in. And then I got into Emory Medical School in Atlanta, and went to medical school at that point.
Yeah. And at what point did you decide that you wanted to be a radiation oncologist? Because there's actually quite a connection from a technology and science standpoint with what you're doing now, especially with proton therapy and particle accelerators and the nuclear submarine that you were on. So when did you decide this is the specific type of medicine that I want to practice?
I think I was in my 3rd year of medical school. I never even heard of radiation oncology.
Okay.
And a buddy of mine, named Chad Levitt, he had come back from UCLA doing a rotation, and we were in Grady Memorial Hospital.
Okay.
And we were in the cafeteria, and he turned to me, and we had gone to high school together. And he had also gone to Emory, he's at Emory, and he said, This is the most incredible field. You've got to, he's always enthusiastic, but he's like, this is the most incredible field. It's called radiation oncology.
Okay.
And, and I was always looking to combine the engineering knowledge that I had with medicine and try to do it in some way. And so I'd never heard of this field. Mm-hmm. So I listened to him and I said, I went up to the rooftop where the library was in the hospital, and I pulled open a textbook, of oncology, cancer medicine. And I looked up radiation oncology, and it was all this physics, and I understood all the physics.
Yes.
And it was very interesting. And then I started thinking, I'd like to learn a little bit more about this. And so I looked for where radiation oncology facility was, and there was nothing in the hospital.
Okay.
But it was outside the hospital. It was like a block down the street.
Right.
So I went out, walked down there.
And this is at Grady
This
Memorial.
is Grady Memorial Hospital. Okay. And I walked in to the radiation oncology facility, and I introduced myself, and there was a resident there. And I said, I just wanted to introduce myself, and I've heard about this field called, what exactly is radiation oncology? Right. And he looked at me, and he said, his name was Stuart Burry. Okay. Remember like it was yesterday. Yeah. Who's now, chief radiation oncologist in Chapel Hill. Okay. Not Chapel Hill, in Charlotte, North Carolina. Okay. And he said, welcome to the best kept secret in medicine.
Oh, yeah.
That's exactly what he said. And we started to talk a little bit. I did a rotation there. Then I went out to MD Anderson. I did a month rotation there. And then I came out to UCSF, and I did a month rotation here. Yeah. Because I wanted to see what the field of radiation oncology was like in different academic environments. And after doing that, that's when I knew that I wanted to go into the field. And I told my father that I wanted to go in radiation oncology. Yeah. He goes, you're not going in radiation oncology.
Oh, really? Okay.
He said, that's just where we send patients and we never see them again.
Right. Okay.
That was how it was perceived in the medical world, about radiation oncology. Yeah. And to your point, the technology, the patient interaction, I think, really drew me. You're on a destination with a patient, and the ability to be part of their curative treatment. It was not just a palliative field. Right. It was a true opportunity to be part of a definitive curative treatment for patients. And so I then was fortunate to be matched for residency at MD Anderson. Okay. And then I came out in 2001 for my residency. Yeah. Stayed on faculty and have been there since.
And when did you first get exposed to proton therapy?
So proton therapy, they started building, Jim Cox, who was my chair at MD Anderson, really believed in proton therapy. Okay. He believed in it so much that he decided to make that a big project for the institution. And in 2003, while I was a resident, they started to build the facility. Okay. They started to build it. And in 2006, which was the first year I had come out in 2005, but it was that first year and a half, we treated the first patient with proton therapy. So I had just come on faculty. I was on both on the head and neck service, and I was on the GU service. Okay. So I was split on two different services, was a little bit unique at that time as well. And then I talked to one of my mentors, Kian Eng, who was really a leader in clinical trial, translational science, and just a great human. I asked him, I said, should we consider treating our head and neck patients with protons? Uh-huh. And he said, there's no role for proton therapy in head and neck. Okay. And so,
because at this time, MD Anderson was one of 3 proton centers?
That's right.
In the country? Yes.
I think it was the first proton therapy center, a comprehensive cancer center. Okay. And so it was Indiana had been out there, but was sort of struggling. Of course, Loma Linda. And so
I guess MGH, was doing protons. So
that's right.
One of 4.
One of 4. Right. That's right. So those were the sort of the ones that existed at the time. And but it made sense to me to consider head and neck. Right. And so I started doing treatment plans, started looking at different ways, working with the dosimetrist, working with physicists, and then started really exploring whether proton therapy could actually be beneficial for patients compared to what we were conventionally doing, And at that time, we had not gotten fully into IMRT. And so most of the plans were done using a pencil on a flat 2D image.
Okay. Wow.
And that's how we drew our fields.
Wow.
When we were taking care of patients. So, the 3D era was just coming into play.
Right.
And by 2008, we started really moving to IMRT as much more of a standard.
Okay.
And in 2008, scanning beam was the first time that we were able to do it. And we treated our first scanning beam patient with prostate cancer.
Okay.
And so that technology was brand new.
Yeah.
That was 2008. That was scanning beam.
Okay.
But that was what we call single field optimization. And what single field optimization is, of course, is that every field gets treated you treat the entire target volume with every single field. So if you have 3 fields, each field is treating the entire target volume.
Okay.
The newer technology that started to evolve was what we call multi-field optimization, where every field that you treats a portion of the target. And that's much more similar to IMRT.
Right.
And you have inverse planning.
Okay.
So I treated our first head and neck patient with oropharynx cancer and nasopharynx cancer.
Okay.
Those were the first 2 patients in 2010, 2011. And that's when it first dawned. It was sort of a light bulb moment for me.
Yeah.
It was a light bulb moment for 2 reasons. One, because I was able to understand that the physics of proton therapy has a major advantage.
Right.
These patients were able to get through treatment, were able to maintain their taste, less mucositis on the anterior cavity, less weight loss, less difficulty swallowing.
Right.
And it was a true aha moment for me.
Yeah.
The second aha moment was a radiobiologic aha moment.
Okay.
And that was with a 33-year-old female that came in with nasopharynx cancer, which was an adenoid cystic carcinoma. And nobody would treat her. This tumor wrapped around her brainstem, and nobody would even treat her with IMRT. Okay. So she came, we sat down, we looked at what a IMPT plan would do. And I said, we are willing to consider this. Let's try it. There were even colleagues of mine that didn't want their name associated with this patient because everybody was so worried. I mean, and there was a lot of uncertainties at that moment. This was a completely unresectable tumor. And by the time after her first follow-up visit, she had a complete response.
That's amazing.
It was unbelievable.
Wow.
And so that's when I recognized that not only was there a physics advantage with proton therapy, with no entry and exit dose, so to speak, or less entry and no exit dose. Right. But from a radiobiologic standpoint, we were dealing with a different type of radiation drug, so to speak.
Right, right.
And that was enough to start me on the journey toward developing a randomized trial. Okay. And the question became, what's the right space to do a randomized trial? Right. And there's not enough patients in the United States with nasopharynx cancer. So that wasn't going to be the right cohort for the United States, definitely in Asia, but not for the United States. But oropharynx, there was a rapid rise in epidemic of oropharynx that was happening in both Europe and America. That was probably the number one disease that was happening to patients. So that became the group of patients that I thought this may be the best to run a randomized trial on. And then that started the development of that trial that we have just completed. Went to the NRG, discussed it with them. They were less inclined to do it because probably for 2 reasons. One, there wasn't that much proton therapy out there.
Oh, right, right. Yeah.
And so most of the NRG groups didn't have protons. Mm-hmm. So that they didn't want to, that was not interesting. That was not an interesting question to them at the time. Right. And so I then went back and started putting the infrastructure together at MD Anderson to initiate the trial. And then when Mayo Clinic got proton therapy, I started collaborating with Rob Foote, and then I collaborated with Paul Bussey up at Mass General Hospital, and we started to develop the consortium. Okay. And that sort of built, as every proton center started coming online, we built out activated 17 different proton centers with 21 different institutions to participate in the trial. So, and that's the 440 patient trial that has led to the completion and then the subsequent reporting out that's coming shortly.
That's an amazing story. And to think that that all started back in 2006 as you were looking at those first proton therapy plans for head and neck cancers. And now here we are 19 years later, and it's kind of the culmination of almost 2 decades of work on your part. That's an amazing history.
It's amazing.
Yeah,
history.
as a history major, you're participating in the history.
Well, when you look at the number of patients that were treated at our Proton Center with head and neck, it was about 3% in 2008.
Right.
When you look at it today, it's like 35%.
Oh, wow.
And it is the leading indication that not only at our center, but I think nationally, and if you look at it internationally, it is the leading type of treatment that is being used for proton therapy. And I think part of the reason, and this is, it's one thing if one center, does it that way.
Right.
And, we've made an effort. We sort of have a motto that no data is left behind. Mm-hmm. We initially put together prospective databases. We published our work quickly. We did case match control studies. We did quality of life studies.
Right.
We put outcome studies. So we did a lot of that publication, and we did that real time to ensure that we could articulate and communicate what the results and outcomes of patients are. Right. And then those studies became validated at Mayo and at other centers as they started to publish their own data. And then when you start seeing repeated data being published, it sort of creates that validation.
Right.
And that's the excitement. Everybody wanted to see a randomized level 1 evidence because the insurance companies still would not pay for it. And even in our trial, we had about 23% crossover of patients in the trial, meaning patients that got randomized to IMPT, but subsequently got treated with IMRT.
Okay.
And that's because insurance denied them. Yep. And then we had patients that got randomized to IMRT, but that their insurance improved it, and then they refused their randomization and got treated with protons.
Okay.
So we added those 2 cohorts into the study.
Okay.
And in fact, we published while we were doing that because I knew that after the trial was over, there was going to be a lot of criticism about the methodologies of the study. And so we published the methodologies along the way to keep everybody informed and updated as to exactly what we were doing and why we were doing it. And I think that's been
fully transparent
as to what the process was and why we needed to do what we were doing.
My last question, you talked about your dad being your superhero and just the fact that him going into medicine was part of your inspiration to go into medicine. And I know you talked about him passing away recently. You also said that he had discouraged you initially from going into radiation oncology. I imagine that perspective changed over time as he saw all of the great things that you were doing, treating patients at MD Anderson with radiation.
Yeah, I think that's exactly right. I mean, as he started seeing and learning about what radiation oncology really was, the impact on patients during their cancer journey, and whether it was prostate, which I also treat, whether it was, and my mother unfortunately passed away as well from cancer.
Oh wow!
She had an unknown primary, and she ended up getting proton out at MD Anderson. Okay, and was treated by one of my colleagues.
Oh wow!
And so he saw her journey go through treatment, and her journey. She was told that she had maybe 11 months to live, and she ended up living 2.5 years, following treatment. So she had a much longer lifespan and journey, following. So I think he saw it not only in his son, but he also saw it in his spouse and his wife and my mother. And, so and I think he definitely came around. And I think he came to understand what that benefit and was a big supporter of me, all along the way.
Well, when I tell people that I work in radiation oncology, of course, I'm not a doctor, but one of the comments that I usually get is, well, isn't radiation bad, right? So like you think of it, people there's this perspective that whatever it is, I go, well, that's where, as your dad said, that's where we send people and they never come back, or radiation's bad, but it really is an incredible tool that we have to fight this horrible disease of cancer.
It is a very unique and important tool. When you think about taking things out and having, surgery, surgery comes with complications as well. And prostate cancer is another example, and even head and neck. I mean, we've looked for ways to eliminate radiation in many different capacities, but that has not happened.
Right.
And I think radiation should be the primary modality for prostate cancer treatment. Patients are able to not get incontinent, able to sustain their erections, better patient satisfaction. And we published our 3,000 patient series recently on prostate cancer, and the results are fantastic with protons. And so I think that is a great modality. When you look at, and that's not going to, and chemotherapy is not going to treat that. Yeah. And surgery causes more complications. So therein lies is a great modality when the tool is used correctly. We're seeing now that we're treating more patients with metastatic disease with radiation to get patients a break from all their systemic therapy that causes tremendous amount of toxicity, and we might even be able to extend people's lives longer. So that data is starting to mature. Yep. And in the head and neck space, when you really start to see for nasopharynx, which is epidemic in Asia, for oropharynx, which is an epidemic rise in the United States, when you see periorbital tumors, and we've done a lot of work where we would normally take the eyes out, and patients would have orbital exonerations when they have these tumors adjacent to their eye. Now with proton therapy, we can not only cure them, but we can maintain their clear vision and their cosmesis. So a huge quality of life, benefit. So I think proton therapy, people, not just in the United States, but in Europe and Asia, you're seeing that rise of head and neck as a leading modality, because any amount of radiation that is unnecessary can have long fibrotic and toxic effects to these patients years after their treatment is over.
Well, thank you so much for all of the amazing work that you're doing, Dr. Frank, and thank you for sharing a little bit about your personal journey being in the Navy and then becoming a doctor. And again, thank you for all the work that you're doing on behalf of patients and the proton therapy community.
Thank you, David. Thank you for all the great work you're doing, helping educate all of us in the community and about the advantages and the history of proton therapy.
Thank you.